Thank you, Chelsea. Welcome everyone to today's presentation, implementing Food Rx programs to improve diabetes outcome and overall health outcomes. I'm so glad that you are here joining us. And before we get started, I just want to really quickly include note on just naming. So we use the terms Food Rx, food prescription, and produce prescription programs kind of interchangeably. So some of you may be more familiar with one of these terms more than another, but we just wanted to clarify that it's all the same, just kind of different terminology that we tend to use. So today our speakers are myself, Megan Martinez, and I am the Health Initiatives Program Coordinator with the National Center for Farmworker Health. And joining us as a guest speaker, we're excited to have Kate Miller Corcoran, Food as Medicine Coordinator with the Rural Health Network of South Central New York. She works with community partners and program participants to get produce from local markets into the hands of community members, creating a healthy, vibrant future for all. So we're excited to be hearing from her today a little bit later on in the presentation. So today our learning objectives include: we will learn about food prescription program models that address the link between food insecurity and chronic disease. We will learn about developing partnerships between the local food system, the healthcare system, and the patient population to address social drivers of health. And we will learn about accessing different resources, including the Food Rx Replication Guide for health centers that we created here at NCFH. And we will gather implementation strategies from successful Food Rx interventions to create their very own personalized produce prescription program in partnership with different local organizations. So first, we're going to start off by covering why. Why do we need Food Rx programs? So there is a well-researched connection between food insecurity, stress, and any chronic diseases. That includes heart disease and diabetes. In diabetes specifically, adults who experience food insecurity are 2 to 3 times more likely to develop type 2 diabetes. And those who already have it, management just becomes that much harder because they may not have access to the proper nutritional food. So as we know, diets that are high in fruits and vegetables and the fiber that they contain are associated with lower rates of any chronic illness, especially with the lower rates of type 2 diabetes. Since people with diabetes pay on average twice as much for healthcare as those without, people often end up having to decide between, do I go without nutritional food or without healthcare? Maybe they don't have enough money for both. Maybe they don't have enough money for nutritional medication, for their medication as well as their nutrition food. So they're in a situation where they have to decide what they choose. Sometimes people who do not have enough money or who are experiencing food insecurity may meet their calorie needs, but they may lack proper nutrition, since nutrition food can be hard to find in some communities. And sometimes the nutritious foods are too expensive. As we all know, sometimes some of the cheapest and most plentiful foods in our society are also those that are most likely to cause chronic illness because they are so high in added sugars, saturated fats, and sodium. So there is a big link between many chronic diseases, including diabetes, and the stress that is associated with struggling to find or to be able to afford enough healthy food. So due to those reasons, an intervention such as Food Rx, which addresses the affordability of fresh fruits and vegetables, is essential to achieving health equity for people with chronic illnesses, especially if they have low income. So you'll see on the screen here, these are some of the benefits that were identified by participants of a past presentation. So just kind of by looking at the screen, if you want to plug in the chat, what is a benefit that stands out most to you? or what have you seen that your patients most relate to when it comes to benefits of the Food Rx program? Like here you'll see an increase in mental clarity, of course, food security, improved mental health, um, increased nutrition education, the feeling of empowerment from participants. So feel free to plug in the chat if there's anything here that sticks out to you, or maybe is there anything that's not on here that you think is beneficial? We'll take a minute to see if anyone would like to share in the chat. I see less stress and more independence. Yes. Decreased stress and increased stability. Great. Nutritional education. Yes. Those are all great. Thank you all so much. Overall, better sense of health, right? So studies on Food Rx program are starting to show some notable clinical benefits. And some of these benefits include reduction of hemoglobin A1C levels in individual with diabetes, improved blood pressure, reduce body mass index scores, decrease of food insecurity, decreased depressive symptoms, and like you all mentioned, improved overall health management, and even they show improvement between patient and provider relationships. So in addition, they appear to result in self-reported increase in overall health because of their increase in food and vegetable consumption. So Food Rx is a very particular intervention because it addresses the root cause of disease that we are usually trying to treat downstream in the healthcare system. This rather moves the intervention upstream, and its value lies in improving social determinants of health, improving overall health, and keeping the costs down. In fact, just recently, a lot of literature has come out on the cost effectiveness of these interventions. One study that we found, it was determined that Medicare and Medicaid participants receiving 30% subsidy to reduce the cost of produce would, over a lifetime, result in $39.7 billion in savings in healthcare cost nationally. So that's a big number. So in order to familiarize you with these programs and what they can look like, we're going to quickly review the three main program models. So the first one that we're going to cover is the voucher program. So one benefit of this program is that it has a high degree of participant choice. So that means that the participants can go and they can pick their foods, pick the foods that they like to cook, or maybe the foods that they are familiar with and know how to use. And that's a difference compared to the food delivery programs where the participants may not have much of an option. So with the voucher program, the healthcare organization identifies the patient needing the food assistance. They provide a voucher or maybe like a coupon and refer them to the produce partner. Patients cash in their vouchers or their coupons for fresh produce and other healthy food staples. So some of these examples include maybe like farmers markets, farm stands, grocery stores, or different native trading posts. Second, we have the food delivery programs. So one big benefit of this type of program is that the produce is delivered to a location that is convenient for the participant, which that's great for those participants who maybe have transportation issues or a lack of transportation. So that's different in compared to the voucher program. So again, healthcare organizations identify the patient and refers them to the produce partner. The partner delivers the produce to a residence or a centralized location, which could include the organization itself. The patients receive their produce or other healthy food at that specified location. And examples of this can be like mobile pantries, mobile markets, or CSA box distribution, which is the community supported agriculture box distribution. And then third would be the referral programs. So I know that referral programs can be limited in reach, but they can be a good option for healthcare organizations who maybe have limited resources. So the way that the referral programs work is that the healthcare organization identifies the patient, connects them to an already existing source of free produce, and integrates the referral process into the workflow to the greatest degree possible. And some of these may include like food pantries that some of you may be familiar with, the Double Up SNAP program, or the WIC Cash Value Benefit program. So in order to facilitate the implementation of Food Rx programs in health center settings, we at NCFH have developed a Food Rx replication guide for health centers. So we're super excited to be able to share this guide. It took a lot of extensive research, a lot of different interviews with different health centers and staff, and meetings to compile all the best resources and information on this topic into one place for you to use. So this guide is designed for health centers, but it is applicable for nearly any healthcare organization or project implementation partner. So it's open for anyone to use. So here on the screen, if you have your phones handy, you can just take off your camera so that you can click on the QR code, and that way you can access the guide and kind of follow along. I'm just going to quickly go through what it entails or what it includes. And I think Maria is also going to plug the link in the chat just in case some of you may not have your phones with you. So I'll leave this up for just a few seconds in case anyone wants to grab the QR code. Okay. So our purpose in creating the Food Rx replication guide was to address the need seen by health centers across the country to reduce food insecurity in their patient populations, reduce the incidence of diet-related diseases, and overall reduce the cost of care associated with preventing and managing these varying different health conditions. So we designed this guide to be as user-friendly as possible to help each of you implement your own Food Rx programs. So with that in mind, we created it to be comprehensive, step-by-step, and always keeping in mind health center staff often had very limited time and sometimes very limited resources at your disposal. So we wanted to create something that allowed health professionals to address food insecurity as a modifiable health risk. So even if they've never taken on such a project before, we're hoping that this guide can be helpful and useful. I do also want to clarify that while this guide is suitable for addressing food insecurity in farm worker populations, it was designed with the patients of health centers in mind. So to say that it can include farm workers, but it is not limited to farm workers. So let's take a look at the different steps you could take to implement your own Food Rx program. If you're kind of following along and looking through the guide on your phone, you'll see that we've broken down the process into 7 steps so that you can, to help get your program started. So step 1 is a health center readiness assessment. And then we go into conduct asset mapping. Step 3, asset partner readiness. And then we jump to developing partnerships. Step 5, exploring additional funding. And then we go into step 6, which is the action planning. And step 7 would be implementing your program. So those are kind of the steps that we're going to go through here. Assessing the readiness of your organization for a Food Rx program is step 1. And here you can use, we have lots of handy fillable PDF forms to self-assess how prepared your organization is to implement a program. And you can really kind of hone in on areas that require improvement before you actually begin. So you can pose questions like, is addressing food insecurity a priority for the leadership of your organization? Because remember that it's very important to have leadership buy-in and their support. Does your organization currently screen for food insecurity? So just out of curiosity, if you want to plug into the chat, do you know or are you currently screening for food insecurity or other social determinants of health at your organization or at your health center? Just kind of want to gauge where everyone's at. Yes, screening for SDOH, perfect. Yes. Yes, for both. Good. So it sounds like many of you all are currently screening, and Maria did ask in the chat if you'd like to share what tool you're currently using. That would be great. Yes, Trinity Health screens for SDOH and records in the medical record. Perfect. Great. So that's good. Then we move on to step 2. And this is where you identify the available resources you could call on in your community or your network to start a Food Rx program. So this is just kind of a sample asset map that we created to illustrate the types of organizations or resources that could help you as you develop your program. This includes things like farmers markets, like we mentioned earlier, university extensions, maybe your state's Department of Agriculture, of course, different funding sources and partners, and health industry leaders. So again, this is just an example of an asset mapping that we've created to help you get started. But of course, everyone's will look different, just kind of depending on what's available, what resources are accessible in your communities and within your networks. So again, just to kind of gauge an idea of where everyone is at, do you have any ideas as you begin thinking about creating your own asset map? What produce sources do you think are available in your area, which can serve as potential partners? So as you kind of, if you want to share in the chat, kind of really start thinking about so that you can begin your own asset mapping. Well, who can I reach out to? What are some potential partners in our area? What's available? So if you want to just plug it into the chat so that we can share. Sometimes it's good to share because some of us may be thinking of like something that somebody else may not be thinking of. So it helps one another. Yes, food pantries, food banks, community food stands, food rescued from retail distribution centers and grocery stores. Yes, local growers network, YMCA veggie van, Heartside Gleaning Initiative, North Kent Connect. Good. So it sounds like you all are familiar with what's in your network. A couple of local food pantries, some churches that have food shelves as well. Someone is food pantry coordinator at Akron Children's Hospital, and they partner with the Akron Canton Regional Food Bank. That's awesome. I love that. Good. Just to kind of spark your mind and kind of get you thinking on what resources are available. And yeah, like Maria said, start connecting those dots and getting your asset map together. Thank you all for sharing. Okay, so once you have identified those organizations that you kind of all mentioned that could serve as potential partners, you'll want to now assess their readiness as well. So we have a couple of readiness assessments that are differentiated by the types of programs that we kind of discussed earlier. The 3 different programs, which included the voucher, food delivery, and referral programs. So you can use, they're super easy to use, fillable PDF forms. That way you can assess how ready your potential partners and organizations are as you begin implementing the Food Rx program. And then we go into step 4. And this is where you actually develop those partnerships. So you've already, gauged what's in your community. You've already identified partners. You've already assessed how ready they are. And now it's time to develop those partnerships. So when you determine that both organizations are well prepared to take on this program, you'll next start building the kind of dynamic partnerships it takes to sustain the program. So while we don't have time to cover all of those things today, here you'll find a couple of recommendations for establishing different kind of roles across the teams, as well as building successful relationships. So again, this is just kind of an example of what you can use to kind of establish the different roles that are needed for your program, such as, are you going to have a registered dietitian? Will you have a board of directors, CEO, COO, maybe community health workers as part of the program, medical directors, providers, medical assistants, and of course, the health partnerships and the coordinators. So again, this is just an example, and you can feel free to plug in kind of other roles as you see fit for yourself and your organization. And now we go into funding. So it's time to explore additional funding. So if you don't already have funding sources identified, don't worry. There are program types for all budgets. But you and your partners may want to apply together for additional funding. So this is why we compiled kind of some common sources of additional funding for Food Rx or produce prescription projects. You'll see here we kind of divided it up into like healthcare funding, grant funding. There's different private fundings, and of course you have your state and local funding. I did also want to share with you, and I think Maria will be plugging it into the chat. There's a link. There's a link to the NIFA USDA government. They actually have a grant opportunity available right now. It's called the GUS NIP Produce Prescription Program. And their goal is to demonstrate and evaluate the impact of projects on the improvement of dietary health through increased consumption of fruits and vegetables, as well as the reduction of individual and household food insecurity, and the reduction in healthcare use and associated cost. So their applications for RFAs opened up on November 29th. So it's just very recent. And if you go onto the website, there's a contact information for somebody that you can contact for additional information. And that person is Mallory M. Koenigs. You can see that on the website. They do have a closing date for submissions, and that's February 28th, 2024. So we encourage you all to get on it. I think I saw on the website that they have about $5 million available to kind of distribute and give out. So make sure to look into that. And I think Maria dropped the link. Yes, drop the link in the chat. And it'll also be included in the follow-up email. So again, every program looks different, right? But we just wanted to make sure you could literally check off the major boxes. So that's why we created action planning checklist. So these checklists are actionable and they're individualized by program type. So while we tried to make them as prescriptive as possible to kind of take that guesswork out, each program does look different. So we included some key decision points to be made by the partnering organizations. And again, that can include different tasks to be done as you coordinate with the partners. They're individualized by program type, and action planning also includes key decision points to be made by partnering organizations like we discussed. So choosing a screening tool, food insecurity screening tool. One decision point is choosing a food insecurity tool for your organization, whether you've never used one or you're looking for one that better serves your needs and the needs of your community. Maybe you're looking to get a bigger picture of what your patients are facing by implementing a screener like the Prepare that scans for more than just food insecurity. Or maybe you're looking to reduce the burden on participants filling out screeners, and you want something that's more simple and kind of quick, that can reliably detect food insecurity. And that's kind of like the 2-question hunger vital sign tool. So this is a very important step as you're implementing the program, choosing a food insecurity tool, screening tool if you don't already have one, or again, maybe you're just looking for one that's better suitable for your population. The Prepare tool, it was endorsed by NAC, and it's already used in many health centers. Maybe a lot of you might be using them, and it's very comprehensive for social determinants of health. And then there is the USDA food security survey tools. And that could be 6, 10, 18 question survey options. So again, it's just a matter of what's best for your patient population in your community. And then, of course, the Hunger Vital Sign, which is the 2-question screener. And it is endorsed by the American Hospital Association, the American Academy of Pediatrics, and Feeding America. And I think Maria posed this question earlier, if anyone would like to kind of plug in the chat and share what screening tools you use, because it's good to, again, learn from one another about the different tools that are being used and what works and what doesn't. So feel free to just kind of plug into the chat if you'd like as we continue the presentation. So another extremely important decision point in choosing the eligibility criteria for your program. I've seen countless examples of how organizations pick the criteria, and that can include like anyone just who meets the criteria for food insecurity, or it can be a combination of any of these things listed, these conditions listed here. It can include somebody who has prediabetes, maybe is overweight or obese, a cancer patient, metabolic syndrome, PCOS, a fatty liver, depression, preeclampsia, IBS, asthma, COPD. It could be, you could choose, choosing your eligibility criteria is completely up to you again. These are just different examples of conditions that you can choose. Common diagnosis include diabetes or prediabetes, hypertension, different types of heart disease. So just things to consider when choosing eligibility criteria. And then patient experience. So in order to ensure a positive patient experience, you'll want to train your staff on screening, enrollment, referral, and follow-up. So one important decision point in this area is which materials you'll develop to support enrollment and education. And here we just kind of have a list of different things that you can consider. It could be like surveys, baseline screenings, overview of the program, distribution times, what would the retail hours be, pickup locations, retail addresses, different instructions, dates, times, appointments. There's just so many different components to consider so that you can provide the best patient experience possible and to make your program as successful as it can be. And again, you may have other things to consider just kind of based on your needs, but those are just some that we gave as examples. You'll also need a system for evaluating and tracking your program. So this is how you know if the program is creating the intended outcome and where you can focus your improvement efforts. So you can see what works, what didn't work, and what you can do better. Evaluation and tracking are especially important if you have secured or would like to secure funding for your program, because funders always want to see outcomes, right? You can track outcomes like disease measures, health outcomes, as well as healthcare utilization of your EHR, food insecurity, and related SDOH from your screeners, and nutrition quality, fruit and vegetable intake, and participant satisfaction, maybe from baseline surveys or post surveys that you decide to do. So again, this is some information that you'll see on evaluation and tracking. And then, of course, we have implementing your program. So now that you've designed your program for success, it's time to actually implement. So as you do so, we did include some tips on monitoring your program, sharing successes and challenges, and just kind of really maintaining a continuous improvement process to always and consistently make your program better with each implementation period. So along these lines, we hope that you'll share with us if you do decide to start a program, or if you start considering starting one. Please feel free to notify us, send me an email. We're happy to help you along the way to help guide you with anything you might need. So before I transition it into we want to hear our guest speaker, Kate. Before I transition to her, we do have a poll question real quickly, just to kind of gauge where it is that you are currently at. So Chelsea, if you can please pull up the poll at this time. Our question is, does your health center currently have a food RX or food prescription program in place? So you can answer, yes, we have implemented a program. No, we do not have any, or no, but we're currently working on implementing one. So again, we just kind of want to gauge where it is that you're at. How many of you maybe already have a program and maybe are looking to improve it? Maybe you've never started a program, but really want to get an idea of how you can be well on your way to starting one and implementing one. So I do see there's much variety. We have about 29% yes implemented a program, 57% have not, and they do not have any, and 14% no, but they're working on implementing one. So good. And hopefully those that fall into the 59%, no, we do not have any, after today's presentation, well, maybe go back to talk to your leadership team again and kind of be on your way to implementing a program, because it's very important, especially for your patient population and to get better health outcomes. So thank you all for sharing. Thank you. So let me see here. So I'm going to transition it on to Kate so that she can share a little bit about her program. Go ahead, Kate. Thank you.
All right. Thanks so much. That was such a great presentation. I wish that I had seen it before we started, because it's an intense process sometimes. But yes, my name is Kate Miller Corcoran, and I am the Foodist Medicine Coordinator for the Rural Health Network of South Central New York. I'm not going to tell you all about our organization, but we do have a rural lens. We are really trying to advance the health and well-being of rural people and communities. And so everything we do is rural advocacy and through a rural lens. Next slide, please. So this is actually where we're located. I like to show this map so people understand that we are we are not located near New York City. We serve these 4 counties. They are very, very different counties. You can see that Delaware County there on the far right has a population of 44,000. It's also the size of the state of Rhode Island. So that's pretty widespread there. And then we've got in Broome County, we have a city center of Binghamton, where I'm from and where we are located. And that has 47,000 people right in the city. So we're working with a lot of various areas. So that has been an interesting and unique challenge. And I look forward to sharing this with you. Next slide, please. Okay. So this is a little timeline of where we were and where we've come. So in 2016, we came together as a region to design our produce prescription program. All those stakeholders that Megan talked about, we brought all of those folks together to see what was going to work, who wanted to be a champion, and we designed a pilot. We started it in Broome County, 1 county, 2 clinics, 3 shopping sites. At the time, I was running a CSA program, farm share program, and I was lucky enough to be one of those vendors. So I've been with them from the very beginning. Now we are in 4 different counties, as you saw, with 23 providers and 50 different shopping sites. And I'll go over those shopping sites in a little bit. I want to note here that in 2020, we brought on community health workers at our organization, and we have found that to be an incredible way to really enroll people. When the CHWs play the role as the produce prescription provider, they have the ability to provide that higher level of wraparound services for patients. I mean, we've talked about this before, and we all know hunger is not a siloed thing. All those social determinants of health all feed into each other. And our CHWs have all the resources to connect that individual patient to the services they need. In 2022, my role was created. I was hired in February, and then in September, we were notified that we had been awarded a GusNIP grant as a meritorious project through ARPA funds. So we had applied 3 different times, and that 3rd time apparently was the charm. And I can talk, well, actually, right now I should say, I want to say that we have participated even before we were GusNIP grantees in the Nutrition Incentive Hub. And if you haven't checked that out online, I absolutely encourage you to do that and join they call it the PPR, Produce Prescription Community of Practice. We meet monthly. You don't have to be a grantee to be part of that. There's a wealth of information on that site. And the community is very, very supportive of each other. So even if you're just starting and have questions, you can find people to ask. When you do decide, if you do ever decide to take that leap and apply for it, because someone said it's a beast, and it certainly is. But they do provide some technical assistance if you are going to apply. So once you get your feet wet with maybe some local funding and some smaller funding, then you can apply for that grant. We started with those smaller grants, and they are much more flexible, which also was a big positive thing. We were able to do a lot of different pilots and try just different ways of implementing the program through those grants. So that's a plug for those nice local grants. Next slide, please. So I'm not going to read you everything on this slide. However, I wanted you to know that we are a patient-centered program, and we work with 3 different groups who rep each individual expertise around the patient. So we start with our healthcare providers. They do the enrollment. We have a survey that we implement at the beginning, and we really want the healthcare providers to see this as an instrument that get people using that preventative care more often. Then we've got our farmers and retail sites, and they're able to share information about their food they're growing and selling. Those farmers and the farmers markets and farm stands are really, really important for this. The farmers in our area love to talk about their food. So it's been a real educational point for our participants. And then, of course, we have nutrition education. So we do send out a weekly produce prescription newsletter by email and by text. We were trying a phone call. It was a robocall, and it was a little confusing for our folks that were getting those calls. So we are going to try doing a monthly newsletter that's sent out for folks that don't have text or email. Just as a note. And then I have my position here, which I just think of, I'm greasing the wheel, just like that scene in The Wizard of Oz where they're all oiling up the Tin Man. I'm the oiler. I just make sure that people have what they need and make sure that we are improving and growing this program. Next slide, please. So how it works. Eligibility. So we screen for that food insecurity, and folks do have to be at risk or have a diagnosis of a chronic health disease, a diet-related chronic health disease. So hypertension, cardiovascular disease, obesity, diabetes, prediabetes. We also do often let our clinicians make that call on how narrow or wide they want to cast that net, depending on their participants and their patients. Our participants do attend 3 visits over a 6 to 8 month period. Those can be in person or remote. At the first visit, they fill out a survey. The second visit is a check-in. We really ask that it is within 2 months of when our patients receive their vouchers or are enrolled, so that they are, so we know that they're being used, and we can find out how to problem solve for folks that aren't able to use them. And the last time we meet, our healthcare providers meet with their participants, is a post survey. So we do survey a lot, but we are trying to make the case that food really is medicine. So we have to have that data, even though all of us on this call probably already know that. Each participant does receive $120 in vouchers, or they can enroll in a CSA or a farm share. So there's different reasons that we do both, and I will talk about that in the next slide, please. All right, thank you so much. So this is what our vouchers look like. They are paper, and they come in a booklet of 120. Those are 24 vouchers of $5 each. So I want to tell you a little bit about how these vouchers work. We receive 60,000 vouchers that arrive in those little booklets. And it is more cost effective to have volunteers come and sticker each individual voucher than it is right now for us to have them printed with individual barcodes. So we have folks come in and they sticker each booklet because we really have found that having each produce participant have their own unique individual ID means that we can track their spending. We know if, folks aren't spending those dollars, we can see where they're spending. And so it's been really, really helpful. At first, we tried to have our participants do it themselves or have the healthcare providers do it. And there just is no capacity there. So we decided to take it on ourselves. Folks can spend those at retail locations and we can talk about, I will talk about all the places that they can be redeemed in a moment. We do have $1 market bucks at some locations so that if folks don't get to $5, they can get market buck change in dollar increments. And then those vendors have a very simple form they fill out telling us how many vouchers were, I'm sorry, I got distracted by the chat, how many vouchers were redeemed at their location and how much we need to give them. So, and they attest that, yes, they were only spent on fruits and veggies. That's the best way we can have them be sure that they're using it on fruits and vegetables. So next slide, please. Who do we partner with? So we have the CSA Farm Share. We find that this is best in a delivery system. We do have some community locations that offer the CSAs, but usually folks that get the CSAs do have transportation challenges, so we can take it right to their house. I like the CSA idea because it's consistent. It's more behavior change because it's coming weekly or biweekly, and people are starting to be introduced to items that aren't familiar to them. So, and folks have that choice with vouchers, which is wonderful. We do notice that they purchase what's familiar to them, which is wonderful, but we do want them to start to expand. So that CSA does push the expansion a little bit. We work with farmers markets. Something I do want to say about farmers markets is that in Ithaca and Binghamton, which are our bigger areas, they have paid dedicated market managers. And those folks have been a little bit easier to work with because they have capacity. Whereas those smaller volunteer run farmers markets, there's not a lot of capacity for the manager to do that vendor education. So you have to be a little more flexible and adaptable to get that information to folks. We also work with independent farm resale stands, which people love. That top left corner with the yellow tent, that's a place called Russell Farms. People will come from all 4 of those counties to visit this place. They do that because Russell Farms accepts SNAP. Russell Farms accepts the farmers market FMNP, Farmers Market Nutrition Program certificates. And they are so helpful. Their staff understands all of those programs and they are just super friendly. Everybody feels so comfortable going there and there's so much choice and bounty. And then we do work with retail grocers. We try to stay within our local grocers if we can. We do work with one regional chain. We know that in our small local rural areas, those supermarkets are starting to close. And if we can support them in any way, even in a small way with our produce prescription, we're helping that community. And in those small communities, we're finding that those are actually the favorite. So in Delaware County that I was talking about, everybody loves going to their local grocery store. Even though we have CSA delivery that will come right to their home, they really want that choice, and they will figure out their transportation to have that choice, which has been very interesting. Working with small local grocers, though, has been a a barrier for technology. We're really trying to figure out like an EBT, or not EBT, an electronic based form of vouchers or a card that we can use, but with so many variations, that's been a little bit of a challenge. What has worked well for us? Creating trusting collaborations, talking. I mean, one thing I can say is the communication. I'm constantly communicating with my farmers, with my healthcare providers, just to make sure we all are on the same page, that our participants are getting the same information from everyone, and really building upon the existing relationships that we have. So our organization runs a farm to school program. And so in some of these communities, we have farmers that are giving us food for that. So I've snuck into those folks and said, hey, we also run this produce prescription program. Would you like to be a part of it? Because sometimes when people don't know about the program, they can be a little iffy. But since they know our organization in other ways, we're using those. So like Megan was talking with that asset mapping, that's exactly it. So our goals moving forward, we really want to center local. We believe that supporting local farms and local grocers keeps local rural communities thriving. But we know it's really hard to center local if there's nothing local to center around. So that's also a challenge at the same time. Where are the farmers? Our farmers, our average age is 65. So we're trying, that farm worker population. So that's interesting. The also biggest challenge we have is transportation. Being in rural areas, it just exacerbates how do people get to their food and what food is available. So what we're really trying to do, like I said earlier, is tap into those delivery systems that already exist with CSAs and any of our retail partners that are working with delivery models. Not a lot of our local grocers do, but that Russell Farms I was telling you about during COVID, they started an online ordering system. So we're piloting delivery with them, and it has been very successful, again, because people have that choice and they get the delivery. So that's been really great. But it is an extra expense for our program because we are paying for the delivery. So we're just working our way through that. Next slide, please. Oh gosh, that's the end. Just kidding. So what I wanted to, I thought I had another slide in there. What I wanted to tell you with what's worked well is that we've really focused on the hyperlocality. So really drilling down into the places that, where are we, where are our patients, and what resources do they have? So at this time, I will be quiet so you can ask some questions. And thank you so much for having me. And if you do have anything else to reach out to me about, this is my information.
Thank you so much, Kate. That was awesome. I love hearing from, it's nice to hear from an organization or who has already implemented the program and kind of hear what's working, what's been challenging. So thank you for sharing. And we will have some time for Q&A, a few minutes. So let me just real quickly, just for time purposes, I do want to have time for questions and answers. So you will be receiving a slide deck after today's presentation. And this is just another, we did work, we visited Pasadena Health Center in 2021 as we were kind of working to create this guide. So they did also share with us a little bit about their program and kind of what they're doing. So if you'd like to read more about it, please feel free to click on that QR code. But again, you'll receive all this information via email. And then this is just another kind of story. It's the Veggie RX program, a different food RX program and organization that has implemented it. So again, feel free to click on the QR code and you can read more about it on your own as well, just for time purposes. And this is a third one as well. We kind of wanted to just include a little bit of different programs and initiatives that are taking place. And I did want to share with you all that we do have a food insecurity learning collaborative that we'll be hosting in February. It's going to be 4 sessions, an hour and a half per session, and it'll be once a week from 12 to 1:30 p.m. Central Standard Time. So please register if you'd like. I think Maria has plugged in the chat, or will be plugging into the chat, the link so that you can register. And we hope to see you all there. And then we do have additional Food Rx resources. Again, please feel free to download our replication guide as well. And these, again, just additional Food Rx resources that you'll have available and that will be emailed out to you so that you can check them out. And this is my contact information, Megan Martinez again. Feel free to send me an email at any time. We're available for any kind of technical assistance. So whatever questions you may have or assistance you may need, we're here to help. And that concludes our presentation. Thank you so much to those who joined us via watching the recording, and to those of you who are here joining us in person. If you can please just wait a few minutes, that way we can have our Q&A, our evaluation, and just sharing of additional resources. Thank you.